Morning. How are you? How are you? You can see them kissing, eh? I'm trying to look cool, but it's not working. Okay, so should we get started? Okay. And Rachel, can they hear us online? Yeah. Thanks so much. Okay. So, good morning, everyone, and thank you for being here on this day for International Childhood Cancer. I'm very, very fortunate to be able to introduce my esteemed colleagues this morning who will be presenting on the highlights of oncology research here at CHEO. But before I get started, I'd like to make a land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived in this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So it gives me the pleasure to introduce my amazing colleagues who form the majority of our CHEO oncologists. So this morning we'll hear from Donna Johnston, Leslie Abbott, Jason Berman, Brianna Empringham, Ravina Ramphal, and Nira Thacker. So to keep with tradition, we'll share some fun facts about our CHEO oncology team. So starting with Dr. Leslie Abbott, so these are quotes. I love. Yeah. So Dr. Abbott loves skiing and has put all three of her kids on skis since they were 2 years old. Yep. She rode her bike across Canada with her husband, then boyfriend, in 2012, a total of 2,500 kilometers in 17 days to raise money for cancer research. She went to the World Masters Swimming Championships in Munich, Germany, and won a silver medal in synchronized swimming in 2000. Multi-talented. Dr. Jason Berman, just one line, but it says a lot. He has an extensive and enviable flu bug collection. Dr. Brianna Empringham is a big animal lover and once managed to stuff a dog, 2 cats, and a bunny in her studio Toronto apartment. Yes, okay. So she didn't stuff the animal. Yeah, she let it attack her. Okay, we will substitute stuff with cram. Okay. So Dr. Donna Johnston was the quartermaster for the Queen's Band in university. This meant she was responsible for the uniforms, which included ensuring that no one was wearing underwear under their kilts prior to parades. I don't know how you inspected that, but that's um, Dr. Ravina Ramphal. Okay, so this is a not so fun fact, but it's amazing trivia. When she was in her 20s, she was actually involved in a vehicle rollover and fractured C3, C4. She spent almost 2 weeks in hospital, immobilized on her back with steel pins in her skull and traction using weighted pulleys to realign the bones, followed by 4 weeks in a hard collar. Every night, the nurses would wake her up at midnight to do a set of vitals. And last but not least, Dr. Nira Thacker. He's an avid necktie collector with close to 70 ties. During fellowship, he used to sleep with neckties on during call. Yeah. So, without further ado, I'll pass the mic over to my colleagues. Thank you. I don't know how to advance this.
There we go. Okay, so the objectives of today are to review the oncology research taking place at CHEO and to review the oncology trials that our CHEO patients are participating in. And as Dr. Simpson alluded to, February 15th is International Childhood Cancer Awareness Day, and so we are giving this presentation in honor of that. We would be remiss without talking, if we're talking about oncology trials at CHEO, without talking about the Children's Oncology Group, which celebrated its 25th anniversary last September. So the Children's Oncology Group we are a part of, obviously, it's a member of the National Cancer Institute National Clinical Trial Network, and it's the largest organization devoted to childhood and adolescent cancer research. There are over 12,000 experts in childhood cancer at more than 220 institutions involved in the Children's Oncology Group, and more than 80% of the 15,000 children and adolescents diagnosed with cancer are cared for at COG institutions. The research has been performed at COG institutions over the last 50 years, and it's transformed childhood cancer from a virtually incurable disease to one that now has a 5-year combined survival rate of over 86%. COG has more than 100 active clinical trials, and there are approximately 12,000 patients enrolled on COG trials each year. And they include upfront first-line treatment, studies aimed at determining biology, and trials involving new and emerging treatments, supportive care, and survivorship. And just to give you, at CHEO, we currently have 10 open therapeutic studies and 1 biology study, and we have studies open for a variety of tumors. We basically have every study open that we can open. We open at CHEO to be able to offer these trials to our patients. And this, I just wanted to show 2 schemas just to show you that COG trials are not straightforward, easy trials. This is the current neuroblastoma trial for high-risk neuroblastoma. Patients are randomized to a standard of care with 5 cycles of chemo, or randomized to include immunotherapy during their induction therapy, which involves us starting chemotherapy at 4 o'clock in the morning in order to get the immune therapy in during the day. And Natalie Gervais in the audience is the amazing case manager who coordinates this whole treatment plan for these patients. And then just to show you, this is the new Wilms tumor trial has 12 arms, I believe, 12 arms. This is just one arm of the 12 arms. So these COG trials are amazing opportunities for patients. And for example, this new Wilms tumor study has an arm that would allow patients to not receive any chemotherapy and to see if they have the same outcome. So these trials really are cutting edge, and we consider them standard of care for our patients to receive care on a clinical trial. So moving along, just to talk, we're all going to talk about 1 or 2 of the studies that we're involved in. This study I'm going to talk about is the Canadian Pharmacogenomics Study Network for Drug Safety. It is run out of BC Children's Hospital by Dr. Bruce Carlton. It studies the mechanistic basic of severe adverse drug reactions, and it's been going since 2004. But in 2018, they started a pharmacogenetics testing program to predict severe adverse drug reactions from chemotherapy, and we're involved in that study right now. So there are 9 programs in Canada that are participating in this, and we look at 3 serious adverse drug reactions, testing for cardiotoxicity from anthracyclines, for ototoxicity from platinum agents, and from myelosuppression from thiopurine medications. So there are 9 testing centers in 7 out of 10 provinces. It's all approved by the RAB, and the testing is done with blood or saliva, so it's a simple cheek swab, and then we send the cheek swab off to the lab in Vancouver, BC. And so far, there have been over 1,700 patients enrolled and results reported for this testing program. Just to show the number of tests returned, so just from in 2023 to 2024, there were over 500 patients who received these results. And this is an example of what the result looks like that we get back. This is the test, one of the tests for anthracycline-induced cardiotoxicity. So they do genetic testing for 3 different genotypes, and then they can predict the risk of cardiotoxicity from anthracyclines. Patients can, this is an example patient, so this patient had an average risk. But if you had a patient that had a risk over here, a very high risk, you could, and there is a cardioprotective medication we use, but we don't use it for every time we give the patient anthracycline. We give it based on their cumulative dose. But if you had a patient over here that had a high risk, we would give that drug. Or on the other hand, there's a lifetime limit of how much anthracycline you can give a patient. But if this patient had a risk down in the green, you could consider giving more anthracycline and going above the limit that we usually set. So it is very helpful in planning for treatment for patients. So it allows optimizing chemotherapy and minimizing toxicity. That we can give a cardioprotectant agent. There's also an otoprotectant agent if we find that if they're in the high-risk group for platinum-induced cardiotoxicity, we can use a protective agent that we wouldn't necessarily use because of challenges in delivery. But we can also increase our monitoring. We can dose adjust for the therapy periods, and we can also consider alternative treatments if they're found to be they have high risk variants for toxicity. So with this testing that they've done, these are the 3 we report on, but they've discovered, with all the testing we've done, they've discovered 26 new genetic variants indicative of risk against 5 severe adverse events in pediatric cancer therapy, and it's one of the largest cohorts of this data, and they estimate that about 60% of oncology patients in Canada received the testing. So it's invaluable for future research as well, looking at minimizing adverse events. And the future directions are that we're going to validate the newly discovered variants and move these forward so that we can help prevent more toxicity from the chemotherapy agents. All done with various computer-aided drug design, et cetera, to figure this out, and will help to minimize risk for patients in the future. And this is our project team, and I'm going to hand it over to Ravina.
Hi, everyone. I'm going to talk about a study that we're doing in collaboration with several other centers in Ontario. It's the Kidney and Blood Pressure Outcomes in Childhood Cancer Survivors Study, also known as the KINDA study. It's led by Dr. Michael Zappatelli, who is a nephrologist at the Hospital for Sick Children, and it is CIHR-funded grant. So before I start, I just wanted to kind of give a nutshell of what this is going to be about. Basically, we're interested in understanding, after patients receive treatment in the first 5 years thereafter, what their risk of chronic kidney disease and hypertension is, and specifically in those patients who have received nephrotoxic drugs in high doses, and or who have had a nephrectomy. So a lot of our Wilms tumor patients would qualify as well. So the reason we're doing this is because currently there are more than 30,000 Canadians who are childhood cancer survivors. And this is great, but it comes at the cost of chronic health conditions that affect the majority of these patients. So over 30% of adults will have, who are childhood cancer survivors, have kidney conditions more than 15 years after diagnosis. And adult childhood cancer survivors are at more than 3 times higher risk than the general population of chronic kidney disease or hypertension. So the reason for the study is because the onset and severity of chronic kidney disease and hypertension in the first 5 years after cancer therapy is unclear, especially when in those childhood cancer survivors diagnosed before late adolescence. We also know that chronic kidney disease and hypertension are asymptomatic, and so you have to screen for them. But both are major treatable cardiovascular risk factors, and our patients also have other cardiovascular risk factors. So they have higher incidence of diabetes, obesity, and lipid abnormalities. And so not understanding what happens in those 5 years impedes our ability to plan early interventions for both chronic kidney disease and hypertension, and we are not able to develop evidence-based guidelines and follow-up. So the other important reason for doing this is because early intervention is critical, and if we can start that intervention before we transfer our patients to the adult services, that would be very helpful and a great start. And also to refine the Children's Oncology Group guidelines and optimize practice on kidney health and blood pressure monitoring in the early years after cancer, it is fundamental to understand the disease burden. And so the hypothesis in this study is that in childhood cancer survivors, chronic kidney disease and hypertension are prevalent, more than 25% in eligible childhood cancer survivors at 3 and 5 years after end of chemotherapy. I do want to emphasize that this is the eligible patients are those who have received a high-dose nephrotoxic treatment or have had a nephrectomy. So it's a select group of patients. And the second hypothesis is that the EGFR, albuminuria, and blood pressure worsen from years 3 to 5 after cancer therapy. What we want to show is that there is an ongoing trajectory of things getting worse over time. So the objectives are to determine in 500 Ontario childhood cancer survivors at high risk for late kidney and blood pressure effects due to cancer therapy, what the prevalence of chronic kidney disease and hypertension is at 3 and 5 years after cancer therapy, and the prevalence of 24-hour ambulatory blood pressure monitoring abnormalities at 5 years after cancer therapy. Then secondly, the extent to which EGFR, albuminuria, and blood pressure worsen chronic kidney disease, and whether chronic kidney disease and hypertension persist from 3 to 5 years after cancer therapy. Does it get better, worse, or stay the same? And whether acute kidney injury during cancer therapy and cardiometabolic risk factors are associated with or modify these outcomes. So the study design is prospective. It's observational cohort study, and it involves all 5 Ontario pediatric oncology centers: Kingston, CHEO, Sick Kids, McMaster, and London. And in total, we are aiming for 500 participants to be enrolled. And so there are 2 study visits, and these study visits occur at the same time as our routine surveillance. So we would, when our patients finish treatment, we will follow them to look for any evidence of recurrence for the first 5 years. And these study visits are just added in. We give the parents or the patient a questionnaire to complete, this chart abstraction for relevant data. And at the baseline visit at year 3, we're doing labs, medical history, looking at acute kidney injury during cancer therapy, medications, and the cancer treatment that they actually received. And then at 5 years, it is updated based on what has happened in the intervening time. There's also a physical exam with anthropometrics and blood pressure monitoring. There are biospecimen collections with blood and urine. And for year 5, there's an optional 24-hour urine collection and 24-hour ambulatory blood pressure monitoring. And then at year 4, there is a contact. It could be in person, but it could also be by phone or video or email. It's a questionnaire to update how the patient is doing, their current medications, and whether they've developed any kidney conditions, and also update the chart abstraction. Is the patient still alive? You'd hope we'd know that, but in case we didn't. New medications since year 3, whether they've relapsed or have a new cancer diagnosis, or whether they've had any ICU admissions, and we send them a birthday card. So this is the final slide. The significance of the study is that it will generate the data that we need and does not currently exist on the burden, the severity, the risk factors, and progression of chronic kidney disease and hypertension in the 5 years after childhood cancer therapy, when early prevention and intervention are feasible. The cohort, the data bank, and the biobank will open many avenues of novel cross-disciplinary research endeavors and training, and the study team will be well positioned to inform and reshape childhood cancer survivor kidney and blood pressure guidelines within the greater extent of childhood cancer survivor health. And that is it. Thank you.
Okay, thanks, Ravina, and thanks everyone for joining us. So, just for the quick reminders and basics is that childhood brain tumors are the number 1 childhood tumor ahead of leukemia. Sorry, my leukemia colleagues, when we include the low-grade gliomas. It's not a good stat to be having, but it is. And to top it, it's even worse because it is the number 1 cause of childhood cancer-related deaths. So, just to see how the challenge that we face with brain tumors, already in a very challenging field of oncology. And before we go to the bedside and what we are doing there, I just wanted to lay the background that we already heard from Donna how clinical trials are over the years have improved survival in childhood cancer. So the importance of clinical trials and how it is almost like a standard of care in pediatric oncology. Having said that, we do have access to consortiums, but for newer drugs, the early phase studies, it's always a challenge. We have almost 10% of the trials that is open across the border. And even when we have those 10% trials, they are actually limited to a very few centers. So they're not equitable in terms of access to Canadian children. And the worst part is that we are not even addressing the global oncology issue where 80% of the burden of childhood cancer lies, because all these drug access and trials are for Western populations. And although we are very proud to claim that there's 80% survival, if you actually take global oncology, the survival is at 40%, right? So it's terrible. So I think there are a lot of issues that are not being addressed. And to make things worse, we know that even access to these limited trials, which are already challenging, is getting worse with the geopolitical situation, because most of the trials are actually US-based consortia, where it is getting more and more difficult for us to get access to already a pool that was limited. So we thought that why don't we actually think it around, because every adversity actually brings an opportunity. So like, instead of going and participating in consortium and trying to get access to them, why don't we design trials in Canada and take them to the world? And fortunately, with the amazing group that we have nationally, we were able to have at least currently 2 ongoing trials which address 50% of the pediatric tumors, one of which is low-grade glioma and the other is high-grade glioma. So the first study that, I can proudly say that, I as well as our entire team is a proud of and are leading from CHEO across Canada and globally is the one for low-grade glioma called Victory. And almost 50% of low-grade glioma children can progress at some point in time and they need multiple lines of therapy. Therefore, we are always in search of new therapies. Conventionally, the treatments were surgery, radiation, and chemo, which obviously comes with its share of challenges. And most recently, we have had, because of the breakthroughs in molecular biology, targeted therapies, which are becoming a mainstay and getting accelerated approval across US FDA. But that is where the second Canadian challenge is, that once they are approved, the access in Canada is even more difficult because we take, because our processes, it's longer before how they get approved. And again, here, clinical trials provide the safest and probably the more sustainable way of getting access to these drugs while they are getting approved in Canada. So this trial is run across Canada, Australia, and New Zealand, and we are combining for the first time chemotherapy with a targeted agent, which is a pan-RAF inhibitor called tovorafenib. And it is a great pediatric drug because the company which actually developed it was having pediatricians on board. So it's oral drug, it's liquid, and it's given once a week for relapsed low-grade glioma, which is what we are doing the study for. And when the study started, it was actually the only means of getting access of tovorafenib for Canadian children. They have since then opened a compassionate program, but as I said, trials are always the safest and the sustainable way of getting it. And then moving on, the second trial is for high-grade glioma, where a specific subset of high-grade gliomas, which is MMR and DIPG, they have a very poor survival of almost median survival being a year, and 8 out of 10 will not even survive for more than 2 years. Again, we had all conventional options for them, which is surgery, radiation, and chemo. But thanks to the biology work done in Dr. Tabori's lab at Sick Kids, we saw that immunotherapy in a specific subset who would die after recurrence in 6 months had 80% PFS at 3 years. So it was sort of a significant sort of paradigm shift which was happening. So we were like, why don't we try it upfront when we are using it in relapse and we are getting such great outcomes? So maybe it's time to try it upfront. So we designed this study which actually gets immunotherapy upfront in MMR gliomas. And this study is the first time we were able to convince a drug company to get LMIC sites as the trial sites on board so that we have a bigger impact. So in this study, we have Canada, Australia, New Zealand, and then we were able to get India and Jordan in for the first time. And we are using immunotherapy before radiation, again for the first time in MMR gliomas, and it's the first trial which actually involves LMIC partners as well. And in addition to this, because it's always a trial comes as economics as well, and somebody has to bear the cost. So I think we also have found a mechanism where these are the IITs which have currently, at least historically, have the best reimbursement, because we cannot match the industry, but whatever we could do with investigator-initiated studies, we have the best reimbursement, even as compared to the COG trials that were giving reimbursement. So this is what we are trying to do from bedside, and hopefully we are working on an international consortium with low and middle income countries, and I'm hopeful when we give this talk next year, we'll be able to talk more about the consortium and it will be in place. But to have a good bedside, we need to have a good bench. And once we have that collaboration going, only then we'll be able to translate things to the bedside. And that is what we are trying to do with the amazing team here at CHEO. So with Sean and Eric, who are here, who are the PIs of the TILS project, for which there is a Brain Cancer Canada grant. And also thanks to Dr. Abbott, we also have an additional CHEMO grant, which is exploring this in all tumors, in addition to brain tumors as well. And TILS are basically tumor infiltrating lymphocytes. lymphocytes. And some of the adult studies have shown this benefit in some of the adult tumors, but not much is known even about the profile of tumor infiltrating lymphocytes in pediatric tumors. And this is what we are trying to achieve, establish a good bench so that we can translate it to bedside then. And the second one is, when you see zebrafish, you have to look at Jason and the other team members that he has got, including a master's student. And we got a CHEO grant for it last year, which is we are using to advance preclinical approaches for pediatric brain tumors with zebrafish models, which not a lot of teams are doing. So Jason has a great lab and they do a lot of work, with leukemias and most of other therapies, and you'll hear Jason talk. But this we are trying to do, which not even a lot of groups internationally are doing, to try and see how we use zebrafish models in pediatric brain tumors and use it not only for understanding the biology, but also translating it to therapeutics. And it wouldn't have been possible without the lovely team. We have Dr. Johnston, who is here, Albert with the neurosurgery team, and Leslie Hamilton, who are a part of the partners in this project. So thank you for everyone for your kind attention, and I'll hand over to my next guest.
Hello, everybody. Thanks for having us. I'm going to talk about the IMPACT trial, which is looking at supportive care in all oncology patients and actually hematology patients as well. So this is based out of BC from Dr. Amanda Wirtz, and myself and Dr. Ramphal are involved in this project here at CHEO. So as a background, we know that physical activity is safe during cancer treatment, even during the more intensive phases of therapy. And there's very strong evidence that it decreases chemo-related side effects and improves outcomes across the board. Not shockingly, it's the same data that extends to a lot of other chronic conditions. It extends to cancer therapy as well. We do know that despite this, physical activity levels of children on treatment are far, far lower. And deconditioning is a significant issue. I would say in my leukemia patients, at least 25% have the rehab team involved because they're so deconditioned that we can't get them home to walk. And so there's a paucity of evidence regarding effectiveness of interventions within this population. You can imagine for families going through therapy, they have a lot of competing priorities, and a physical activity intervention may not register as something that's really critical at the moment. And so this is a study looking at an intervention which is basically a supervised physical activity intervention by an exercise professional. So it's distinct from PT, who is almost always involved in our patients. And it's developed by video conference. And it was made out of initially Alberta and then extended to be upscalable, on a national level. Exercise intervention in this way is not currently integrated into the standard of care for oncology patients. And I actually spent a lot of time trying to find good physical trainers and gym people that have some sort of knowledge about normal limitations during cancer that can work with my patients. So there was a pilot study initially done in Alberta's Children's that showed a high interest, but drop off in participation. So they had 93 referred and interested initially, and then 14 consented and 12 actually completed the intervention. So 12 out of 14 is not bad in terms of completing the intervention. However, adherence to all the physical activity sessions was around 57%. So this mimics some of the other research that's been found in physical activity interventions, and I think a lot of people's personal experience that it's very easy to intend to do physical activity, but maybe not so easy to follow through. So this would be the initial recruitment poster for it, and there are a lot of incentives like getting a Fitbit and all these things that were used to get children interested in the program. And this is a study that had challenges in terms of retention. And so this is a picture of the in-person sessions that they were doing. They also did do video conference where you have exercise professionals with a parent present in the younger children. Parents don't have to be present with the older children, but they're using a play-based physical activity intervention that's not standardized across the board. It's individualized to the child that's participating, depending on what their specific limitations are. And so because of this initial pilot study, they've upscaled with a big implementation, basically first step. So they're calling this phase 1. This is a large-scale gathering of information regarding motivating factors and barriers to participating from patients, survivors, carers, and healthcare professionals. So anybody within our division is eligible to take part in this study. It's a one-on-one consultation, and they are collecting some demographic data as well. Basically, any patient that is on treatment or off treatment is also eligible for the study, and also their parents or whoever is taking care of them. Phase 2 will be an upskill the intervention across participating centers. I'm involved in this project specifically around the health economics of it, which is my master's background. So looking at the cost of the intervention, we'll be using a microcosting approach. And part of the advantage of video conference anything is it's a lot cheaper. And we'll be looking at quality of life measures, so the cost per quality of life adjusted year and reported in Canadian dollars. And so the PEDS-QL cancer module, we're lucky in pediatric cancer research that we have validated quality of life questionnaires that can be used in terms of understanding impact on quality of life in these kids. We're also looking at other things like overall outcomes, so mortality and admissions, in terms of impact of this intervention. So I think understanding what's important to families and patients in a physical activity intervention is important, particularly in kids with cancer, because there's a lot of different things that are going on at the same time. And so understanding what makes this, what we can do to make this feel important as well is also an objective. And then understanding how to effectively engage with the children themselves, children and teens themselves, in terms of motivating them to participate. Like we know we can offer physiotherapy every day, and our patients will not participate in physiotherapy every day, depending on who they are. And so we can offer interventions. That doesn't always mean they're going to be uptaken. I think the question is like, is this cost effective as well? And that will depend on the outcome. And then should this be implemented as part of routine cancer care? So acknowledgements to the entire impact team. This is the PI, Dr. Amanda Wirtz. This is the entire team. I haven't included myself or Dr. Ramphal on this list because we were already mentioned. But yeah, thanks for listening.
Thanks, Brianna. Okay, so I'm up next. I'm going to talk about fish. I wore my fish socks today in honor of that. And my Fluvogs, and a pair of Fluvogs, yes. And, Nirav already made reference to the importance of the bench to inform what we do at the bedside. And so I'm going to talk to you about two projects at a very sort of high level today around that we think are going to help with precision pediatric oncology and maybe even cancer prevention. So one of the things that we've been working on in my lab, really, that started back in 2009, and we were one of the first groups in the world to do this. Now this is a sort of an entire field of using the zebrafish as a preclinical precision cancer model by transplanting human cancer cells into the fish and looking at response and using that response to predict the response in patients. And as probably many of you know, the gold standard for this is mice. And while mice are a great model and certainly closer to humans in being mammals, the challenge with doing this in mice is that you need to use immunocompromised mice because when you're transplanting human cells into the mouse, they would reject them being foreign. The process takes a long time. Usually it takes months, if not up to a year, to actually get engraftment. And in some cases, you actually can't even get engraftment. And the problem with that is that time frame doesn't allow for real-world, real-time interventions, particularly in kids with hard-to-treat or relapsed or refractory cancers, where you often need to make a clinical decision around treatment in a matter of weeks to days. So we wanted to see if we could improve upon this timeline by taking advantage of the zebrafish. This is a little schematic that shows you that we can take human cancer cells from patients, we dissociate them, and so this is taken taken at a biopsy, might be a bone marrow, might be a needle core biopsy, dissociate them into single cells, remove dead cells, fluorescently label these cells, and that allows us to take advantage of the fact that the zebrafish larvae, we're doing this actually in the larvae, the baby zebrafish are transparent or translucent for the first number of days, so it allows us to see these fluorescent cells just with a fluorescent microscope. And actually, zebrafish don't develop a fully formed adaptive immune system to about a month of age, so it means we don't need to have immunocompromised fish or use steroids or radiation. Then we can transplant the cells into various sites. This is showing transplantation into the yolk sac, which is sort of analogous sort of to the placenta. It provides nutrition for the fish for the first few days of life. And then you can see sort of the schema there of, we inject the cells on day 2. We then treat with drugs on day 3, and then we can dissociate and we can look at the response. And again, we've been doing this approach and optimizing this and refining this for now well over 10 years, 15 years, and have done this with a variety of different tumors. And so this just summarizes a recent publication that we had in Cancer Research Communications in collaboration with a group in Australia. So the profile group, which is now the profile program, which has now been absorbed into the Access program, is a pan-Canadian program to try to improve access and treatment for childhood cancer in Canada. The Zero Childhood Cancer program is a similar program based in Australia. And what we did with this group is in Australia, they had a number of patients with relapsed refractory tumors who they had good clinical data in terms of response, and they also had good mouse PDX or patient-derived xenograft models where they had treated the mice with different drugs, different treatments, and then were able to correlate that to the patient and the patient response. And so what we did retrospectively is we had these samples shipped from Australia, so this speaks to the fact that you can do research across the world, and then transplanted them into fish and used these same treatments to see what the correlation was. And this is obviously represents years of work, and this was all led by Nadine Azam, who's a very talented research coordinator in my lab. And what you can see here, I think, is highlighted for a variety of different solid tumors that you can see the patient response, and you can see that the fish response actually mirrors the patient response and mirrors the mouse response. And importantly, you can see in a number of cases this occurred where you couldn't even get a mouse PDX because they wouldn't engraft. And importantly, we were able to do these responses within 7 to 10 days. So really in a clinically actionable time frame, and you can see the summary there of the consistent drug response with the patient. So we really felt this was proof of principle, and as Nirav said, we're now looking at this in a number of different tumors, including in brain tumors funded by CHEO. I'll give an example of how we've done this now in a prospective way. So this was a project in collaboration with a group in Vancouver where a colleague of ours, Karen Strallendorf, had a patient, a very rare tumor. I'd never heard of this before, called a settle tumor, which stands for spindle epithelial tumor with thymus-like elements, a refractory tumor. And this tumor came back a couple of times in this patient. So this was like the third relapse, and really they had no idea what they were going to use to treat this patient. And so they sent us samples, but what we did was, and this summarizes a lot of work, they did as part of the profile program, they looked at whole genome sequencing and really didn't find any targets. And so they moved from whole genome to whole proteome. So there really was a bit of a silent genome here. They did the proteomics. This was done in Philip Lang's lab at UBC. And through proteomic analysis, they identified so this is a volcano plot. For those of you who may not be familiar with seeing this, where the blue are proteins that are down-regulated or not expressed, and red are ones that are expressed at a higher level. And SHNT2 came up, and you can see the pathway in the middle. It's involved in folate and 1-carbon metabolism. Now, what's interesting is a drug that specifically targets this is sertraline, which is a very common antidepressant. And so this idea of being able to repurpose drugs. And so what we did was we then looked at sertraline in mouse models, in fish models, and in CAM, which is chick allantoic membrane, which James Lynn at UBC does in his lab. And you're able to see here, this is the CAM model that when you use sertraline and you take the tumor from the patient and put it in there, you're able to see a response if you look at day 3 and then day 5 with different doses of sertraline. And we were able to see this as well in zebrafish-based models. And actually, we then looked at another drug that works in this pathway, actually as trimethoprim, looking at Nicole, again, a very well-known antibiotic. And while we didn't see synergies with these two drugs, we did see... We did see responses with both those drugs. This is really interesting. It allows us to show you preclinically that you can get a response. And then most importantly, we then took this actually to the patient. And when we took this to the patient and treated the patient with sertraline, you can see here the CT imaging and the graph on the right. While it didn't shrink the tumor, you see there's still progressive tumor growth. It really slowed the tumor growth, and that's highlighted by the curves on the right and the time frame pre-sertraline and post-sertraline. So really, this treatment was informed for this patient based on what we saw in fish and chick models. For the second part of my presentation, I'm going to go quickly because I'm conscious of time, because Leslie's going to present as well. Treating hard to treat cancers is really important, but preventing cancers is even better. And so we know that there's a number of cancer predisposition syndromes that predispose kids to develop cancers. Leaf-Raumaini syndrome is probably one of the best known, and we've been working on Leaf-Raumaini syndrome in collaboration with David Malkin and his team in Toronto for over 10 years now. These patients develop a large number of tumors early, and specific tumors, particularly sarcomas, certain types of brain tumors, breast cancers, etc. And you can do surveillance in these patients, as shown by work that David and Anita Villani have done, where if you image them earlier and start treating them earlier, you have better outcomes. But the surveillance is pretty laborious, involving whole body MRIs and ultrasounds, and we can't really predict which patients develop which tumors. We do know that in Leaf-Raumaini syndrome, the mutations are in the TP53 tumor suppressor, which is the most commonly mutated gene in somatic tumors, so like in spontaneous tumors, but also in germline. And you can see in what's called this lollipop plot on the left, you can see there's correlation of some of the very similar mutations, but the frequency of the types of tumors are different. And so the idea was, can we predict based on the mutation what kind of tumors these patients would have and at what time points, so that we can better do surveillance. And P53 is very well conserved in the zebrafish, and so what we did was we made zebrafish mutations for some of these zebrafish models of some of these most common mutations. And again, we can use the transparency of the zebrafish here to look at response. So these are zebrafish larvae. This is the wild type P53 null, so they don't express P53, and then the two mutants that we formed, and we did this using CRISPR technology. And this is using an assay called acridine orange on live zebrafish. And acridine orange labels cells that are dying, undergoing apoptosis. So when you expose them to 30 gray of radiation in wild type, you see lots of dots because they're undergoing apoptosis. If you don't have P53, you don't see lots of dots because they don't undergo apoptosis, which means those cells can stick around longer and acquire mutations and become malignant. And then similarly in the mutants, you see reduced levels of apoptosis. And you can see that on the graph as well. And so the idea is that we can use, I'll show you, the idea is that we can use this as an assay to actually predict which drugs may be able to prevent tumor formation, which I'll show you in a moment. As these fish grow up, they actually develop tumors, so that's important. As they become adults, they, as you can see under morphology, the gross morphology, they develop a variety of different masses, and those masses, when you look under histology, and this was done by Craig Midgen, a pediatric pathologist in Halifax, they develop various types of sarcomas, which is a common tumor in Leaf-Raumaini syndrome. And so then the idea is, could we prevent tumors by taking these fish, treating them with various restorative compounds, and looking at apoptosis using that assay in the larvae to predict which drugs may restore apoptosis to prevent them developing tumors as adults. And then we have a variety of different assays that we can use in the fish to look to determine if this is P53 dependent or not. And there are a number of drugs, drug libraries, even common drugs like metformin, which is an anti-diabetic drug that have been suggested to have efficacy in P53 restoration. And so we're also doing some in silico drug screening to identify other compounds. And this work is ongoing and has been supported by CIHR. And with that, I'll pass it to Leslie.
Good morning. That's a hard group to come at the end of. Such impressive people I get to work with. So I'm here today to present a couple of studies that I'm leading. So this study is looking at the quality of life of patients on early phase clinical trials in oncology, and it's a national Canadian study. I'm lucky enough that this work has been supported by the Kindred Foundation, the C17, Childhood Cancer Canada, and bridge funding from the CHEO RI. So background, why did we ask this question, is that an early phase trial is really the first use of that drug in a child, and patients who have relapsed or refractory cancers would often be the ones eligible for early phase clinical trials, but they have very few therapeutic options. And then we don't really know the impact of that trial participation on the quality of life or symptom burden of a child. And we thought that that could be helpful to inform future clinical trial design, as well as to provide value for consenting in the consenting discussion, not only for the clinician, but for the patient and family. Perhaps to understand that maybe my quality of life won't be affected if I go on this trial. That was somewhat of the hope in the beginning. So this is a cross-Canada study. We have 11 sites open, coast to coast. The eligibility is 2 to 18 years of age. Arm A are those patients with a relapse or refractory cancer who are enrolled on an early phase trial. And Arm B are patients who we like to describe as at a similar point in their journey. So they have relapsed or refractory cancer. Either they're not eligible for an early phase trial, there wasn't one available to them, or they declined it, or they had another option. So we used both the SPEEDY and the PEDS-QL acute cancer module to look at the quality of life. Today I'm only going to present the PEDS-QL data. So this is just an example of some of the questions. This is not all of the questions. And in the PEDS-QL, the questions, they have them broken down into age groups. So this is just an example for 5 to 7-year-olds. We measure this at time point 0. That doesn't have to be the time that you entered a clinical trial, but it's the time that you agreed to be on our trial. And then at 4 weeks and at 8 weeks. So some of the questions are around pain and hurt. Some of them are around nausea and how you're doing with that. We have guardians answer for 2 to 18 years of age, and patients 5 years plus would answer these questions. And as you can see from this scale, if you have a higher score, that actually means a worse quality of life. So the demographics, roughly the same age group, around 9 to 10 years old would be the average age. We have 31 at the time of this analysis on the early phase trial arm and 49 on those who were not enrolled. As you can imagine, that was a bit easier of an arm to recruit to. We have a male predominance in both arms, and the majority of patients in both arms were at their first relapse, which we actually found, we thought that it was going to be patients who were multiply relapsed, but most of the patients were on their first relapse. So diagnosis-wise, this is not surprising based on what Dr. Thacker presented, that if you look in that purple color, the majority of patients in our trial who were enrolled on an early phase trial had a brain tumor followed by neuroblastoma. For those not enrolled on a trial, the majority were patients with leukemia and sarcoma. And I would say, as from a clinical point of view, that's actually not surprising either. Leukemia has been very fortunate that there are lots of things that can be done off study. We have access to CAR T cells, blinatumomab, inotuzumab, bone marrow transplant, and a lot of that is not on study. Sarcoma, unfortunately, as Dr. Ramphal knows, has the opposite story, and that there really is not a lot of option and not a lot of early phase trial. So that's why we see that blip there. So this is where we're looking at the data itself, and looking at, in the blue would be those enrolled on a study, red would be those not enrolled on a study, and then we have the parent and proxy and the patient. And by looking at this, you might initially say those enrolled on a study have a higher quality of life that looks like it was maintained. This was not statistically significant, but what we can say from this is that being enrolled on an early phase trial does not negatively impact your quality of life. So limitations of our study, and this has been our criticism of the study all along, is that Arm B is quite a heterogeneous group, as I explained. Overall, it's a small sample size. We have a few more patients enrolled since this data analysis. We're looking at a total of 92, so we're almost there. We just need 8 more patients on an early phase trial. And we did have difficulty enrolling patients on the early phase arm, and we asked the question, why? So we do have some data to support what I have listed here. So one is availability of trial. So early phase trials have traditionally been available at the 3 largest centers in Canada. So that is also an access point of view. So we're actually working hard here, Dr. Thacker, Dr. Berman, Jenny Lee, many others, to bring more early phase clinical trials to Ottawa. And then in some cases, there are other options that are not on trial, which sometimes can be attractive because we think maybe being on trial is a burden or might affect our quality of life, which we've shown with this data that it doesn't seem to. So the key takeaway points here are that patients enrolled on an early phase trial had no difference in quality of life scores compared to those not enrolled, and being enrolled on an early phase clinical trial did not alter quality of life from baseline. Before I switch to the next study, I just want to acknowledge Donna and Nirav, who both covered me on this trial during maternity leave, Jason and Nirav, who are part of the advisory committee, and I'm looking at the 2 amazing CRAs in the back, Kendra Rodden and Isabel Laforet, who without them, I would definitely wouldn't be talking about this trial in this manner today. They turned things right around in this trial. So these are all the institutions that have been involved, and we're really proud of the collaborations that we've done in this trial. So the next one that we're currently recruiting on is, again, looking at TILs, or tumor-infiltrating lymphocytes. So again, back to the purpose as an oncologist and the clinician, I always want to cure the cancer, but the next thing I want to do is limit harm and limit long-term side effects for patients. So I'm lucky enough to work with Sean and Eric, who are, I didn't see Sean. Maybe he's here, but Eric is here today, and we have a CHEO innovation grant for this study. So we're looking at all lymphomas and all solid tumors. We're trying to get a sample of that to the lab in a timely fashion, and then within a tumor sample, we always know that there's T cells. So Sean and Eric are trying to isolate those T cells and see if they can expand them. And then the goal one day would be that we could potentially inject those T cells back into the patient to destroy the tumor. The evidence so far for TIL therapy is mainly in melanoma, where it's worked exceedingly well. So this is the first time that this is happening in pediatrics to actually do a proof of concept. And we decided to be very robust to try to get all different tumor types. We're also looking at patients before they get treatment and patients who've had some treatment on board to see if there's a difference. So far we've enrolled 9 patients, and we've gotten 6 patient samples. So what happens is the sample from the surgeons goes to the lab. It's in the pathology lab. First and foremost, whatever is needed to be done in the pathology lab must be done for good patient care. And then if there's anything left, that will go to the scientists. So that's why not every sample ends up going to the scientists. And I just want to call out Dina in particular on this study as well in pathology, who's been instrumental and a key collaborator to make this happen. And then you can see all my wonderful surgical colleagues and Gali and IR who have been quite helpful and instrumental in this project. So that's the end of our talk, and I just want to acknowledge here that we have some truly outstanding clinical research associates, coordinators, assistants who work in our division. Without them, this work for any of us would absolutely not be possible, so they support us in the most tremendous way. Thank you. Okay, so yeah. Oh, Sean is here. Dr. Ward, this is a wonderful research portfolio by the Oncology Group. Congratulations on the development and implementation of this important work. Thank you, Dr. Ward. Any questions? Sure. Yeah.
Is there a link to the pediatric?
Yeah. So almost 50% will have a specific BRAF alteration, mutation, or fusion, and almost 80 to 90% have activation of a MAP kinase pathway. So essentially, even beyond just BRAF alteration, we can use MEK inhibitors or MAPK inhibiting agents in majority of low-grade gliomas. And even some high-grade gliomas actually have BRAF alteration.
Left to speak.
I'll ask a question for comment. So obviously, I have bias asking this question, but just looking at the progress that's been made in pediatric oncology related to the organization of clinical trials, is there advice that you would give for other specialties or even our institution as we try to bring therapies closer to home to make them available for rare diseases?
Yeah, no, I think great question. I was hoping somebody will ask. I get to, yes. Uh, yeah, so I mean, culturally, I think historically we've always been lucky, right? There have been groups within CHEO who have been doing great work with clinical trials, right? And I think, but there is always a need now, knowing what's going on and how therapies and access has changed over time, and how impactful they are, and how delayed we get here in terms of getting those. I think. Clinical trials is the best way of getting them safely and sustainably, because you always can't rely on the drug company to give that. So I think there has always been a push, and now I'm very happy and proud that at CHEO it seems not just in oncology, because we were already sold, right? There is already a CHEO who already knows, and we don't have to preach to them. But culturally, I think it's very important for us all to recognize that clinical trials is not just research; it is almost in pediatric diseases and rare diseases standard of care, and probably the only access to life-saving therapies. So I think it is about time where, even as a group, not just at CHEO, but even nationally, we actually think of clinical trials not as research, but as a collaboration to get access to our kids in a timely way and save lives. Hope that was
Go ahead, Joe.
Oh, thanks. Question from a non-oncologist point of view. I've always been respirology, for example. I've always been envious that virtually every patient you have, your goal is to enter them into some sort of clinical trial. Going back, so when you were a resident,
And you told me not to go into
I
oncology
told you not to go.
for respirology, but that's a conversation.
I didn't say I always gave you good advice. One of the things that struck me is you guys were the best at, before even the oncology networks, you had patient registries. And it seems that that's almost like got to be the foundation of going to the next step. So are those, looking back, is there other things that you would say you have to have in place before Dr. Stimson's question would be answered?
I think one of the reasons we've had such strong registries is because we have provincial oversight on like cancer research and registry is often from these overarching, and probably Don is the best one to answer this from a POGO perspective, but because we've had the Pediatric Oncology Group of Ontario, they have really streamlined that. And so I think because we've had organization from a very high level, it's been easier in terms of registry.
That's at the national level, but even internationally, there's been a greater coordination and effort across your specialty than any other I can think
I think you have to have a bit of a coalition of the willing, right? People have to be willing to work together, and that sometimes requires removing, there's a bit of an ego piece of removing that ego so that people can work on a trial. There's obviously going to only be one chair of the trial that may be based in one center, but there's still the opportunity to enroll, and those types of things, which I think of overall.
I think it's about common ground. You have to start at common ground. And I think when you've seen enough patients, when you have no options for them, you don't want to keep having that talk. So I think that unites people in common ground of this is actually rare, but we can get further ahead if we work together. So that's my personal thought. You have to start there.
Progress you've made is tested.
Yeah.
Hats off from every other specialty.
There is a question from Dr. Bug we don't want to miss.
We're just going to answer a question in the chat from Dr. Bug, and then I'm going to. So for early phase clinical trials, how do you decision making, since there seems to be multiple trials and options? So I would say sadly there are not actually multiple trials and options at the time of the relapse. So for example, neuroblastomas, the big phase 1 center we send our patients to is Sick Kids, and they've had 3 trials open, but at any one time we're fortunate if there's one open, because they'll enroll a patient, and then when they reach, say, usually it's 6 patients, the study closes for an assessment, and you have to wait for it to reopen. And so at the time of relapse, we usually don't have multiple options, and if we do have multiple options, it's a discussion with the family as to what the best is. But while there usually are not a lot of options for our patients that they have to pick, it's a bonus if we are in a state where we do pick, but usually there's only 1 or 2 available. I'm just going to talk about registry briefly. I'm going to put the POGO hat on. So the Pediatric Oncology Group of Ontario started their registry called POGONIS in the 1980s, when the group of oncology centres across Ontario came together to standardize oncology care and oversee oncology care and provide the best care. And biased, obviously, but I think it's an amazing model, and it's been adopted across. That we should all work together. Children's Oncology Group was 2 different groups that came together 25 years ago. They were 2 competing groups, Pediatric Oncology Group and Children's Cancer Group. So it's by all coming together. In terms of registries, so POGONIS is the Ontario registry. It's been since the early 80s. It's a wealth of information on childhood cancer. But now there is CIPC, which is the Canadian Cancer for Young People Registry, which POGONIS is entered, and that's been 15 years that we have this data for all oncology patients in the country, which is just a wealth of information and it's being used to improve care across the country. So we're really, really fortunate to be, I think, to be in Ottawa, to be in Ontario, to be in Canada, and then internationally the groups, the SIAP, the International Society of Pediatric Oncology, really helps to coordinate care, and the biggest impact I think they have is low and middle income countries, helping to bring developed country clinicians and treatments to the low countries. So I think it's the best specialty, and we're really fortunate in the working together.
For those who don't know, Donna is the medical director of POGO. And I think the first woman. Yeah. Rob, did you have another? No. Oh, okay. Christian? No, I'm sorry.
I was just going to make a quick comment. Clinical trials is a team sport, so you need to get lots of disciplines, not just sites, but different disciplines involved. A strength that we have here at CHEO, we now have the trials support, but also the clinical research unit. When we, the CRU, when one of the best values the CRU brings to trials is automated reporting. So you can see from week 1 what the data is looking like. And through the life cycle of the trial, you have different opportunities to tweak and refine your data quality. And that's where the scientists, the biostatisticians, and the coordinators work really well together. So that's another resource that you can leverage here at CHEO.
Mine's a very quick question. You can give a yes, no answer. But I wanted to know, just congratulate you. It's really fantastic and very inspirational. You mentioned CAR T-cell therapies. Do you guys have plans to bring the CAR T-cell trial here, or because I know that the adult oncology oncologist and CAR T-cell. So I'm just curious, when's that going to come to?
That's a government of Ontario question.
Okay. So not a yes, no.
It's not a yes, no, it's a complicated.
Yeah.
But that is our hope, I guess,
Yeah.
would be the best way to say it.
Yeah, just same as Donna said, vision-wise, yes. And also, we're working with, we have a great team with CBS, Dr. Magandi, who actually works with cells now, including CAR and NK. And we are hoping that we are able to form that collaboration with having biokinetics also in Ottawa, that we are able to hopefully leverage that for, not just CAR T, but other cell therapies and probably gene therapy. So hopefully that comes.
Right now, CAR T cells in Ontario are still coming up from Toronto.
Okay, thank you.